Dear friends, I'm Dr. Venkatesh, consultant urologist, renal transplant surgeon, and robotic surgeon, and I'm also your faculty in NEET SS and INISS covering urology from team DocTutorials and RRM Next. Okay, so now we are this is a program for MS General Residency program where we are focusing on the clinical aspects, trying to teach the clinical aspects of various subspecialties for those postgraduates who are doing their general surgery residency. So this will be more like a clinical based session. Okay, so like in your final exams also you tend to get ASCIIs. ASCIIs are nothing but some clinical based questions wherein you will be projected with certain CT films, you'll be shown with certain specimens, you'll be shown certain bedside procedures, and you'll be asked questions based on that. So the whole purpose of ASCII is like to have a very simple, common, clinical based knowledge. So the OSCE is not meant to test your theoretical depth of knowledge or something. So whenever you face any questions in clinical viva voice or any OSCE, the idea is very simple. Keep your mind open. Just there will be lot of clues in front of you which will fetch you to get the answers, and you have to be you have to use your common sense in priority. That is very important, because whenever you see something, just use the clues, visual clues or whatever the clinical clues they give, and try to come into a simple clinical diagnosis. Okay, so today we will be discussing on various OSCE based questions which I have framed from urology. So one thing which is quite unique for most of you, like you may not have been exposed to this urology subspecialty during your MS residency days, unlike specialties like GI surgery or surgical onco, because that is in all probability they are just an extension of a general surgery, whereas in many places you may not have a well-versed urology speciality, and you may not have exposed to urology per se directly. So I will just try to help out those students to get some clinical acumen on it. Okay, right. First is a projection. So here the questions will be simple. So initially I'll be projecting few image based questions and we'll try to find the answer. So now I want you to go through this thing. Identify this image. Okay, so here you could see a series of CTs. So given by this, it's a cross-sectional image. Okay, so once you see a CT, then you have to identify whether this is a plain image or a contrast image. How to identify? If you see here, if you see closely in these kind of images, you tend to see there is one structure which is opacified, which is white in color. So this is probably an arterial phase. Also, if you see, the kidneys are well opacified. Kidneys is probably in the corticomedullary. It is probably in the corticomedullary phase. Okay. So and if you see here, there is a heterogeneous heteroechoic lesion. Okay. There is a heteroechoic heterogeneously enhancing mass lesion in the left kidney. So probably we are dealing with the left renal mass. Okay, that is how you have to identify. Okay, so if you see here, this is a coronal section where there is a the normal reniform shape is lost. That means the lower pole and everything is fine. There is a heterogeneously enhancing mass lesion seen arising from the upper pole of the left kidney. Okay, upper pole of the left kidney. That is how you have to come with the diagnosis. So what are your observations? The observations are, there is an irregular heterogeneous enhancing mass lesion in the left upper pole. What is the most probable diagnosis? Any enhancing mass lesion in the kidney has to be considered as renal cell carcinoma unless proved otherwise. So how do you evaluate? So remember, whenever you see a malignancy, then you have to stage the disease. So what is a staging? Staging goes by CE, CT of abdomen and pelvis, and you should also do an LFT, RFT, chest X-ray to look for any pulmonary mets, etc. And how do you manage? Management is simple. Remember, RCC is both chemo and radio resistant tumors. Okay, so the treatment is invariably surgical excision. So what is the preferred surgery you do? Especially if it's a localized or locally advanced disease, you have to go for a radical nephrectomy. Okay, right. So that is the treatment of choice. If it is metastatic, then you have to go for palliative chemotherapy, palliative immunotherapy. What is the next? We'll come to this. So this is an intraoperative picture. There is something is being done here. Can you identify? Remember, this is a penis. They have degloved the penis. They have applied a feeding tube, and it is probably a tourniquet which is wound around which has gone around the penis, and they are injecting, it's a saline. They are injecting something inside the using a syringe. Okay, they are injecting into the corporal bodies. Okay, what is it? This test is called GT's test, or intra or artificial erection test. Okay, so what we are going to do, we are going to inject the intracorporal bodies with saline inside, then by thereby we are artificially causing erection. So where do you do? Usually we do it whenever you suspect a cardi. This is common. This is a commonly used test done during hypospadias repair. Okay, hypospadias repair. Okay. So after correcting card D, you will have to check whether the card is corrected. So you do a GT's test. Now we'll come to the next question. Identify this instrument. See, remember this is a special instrument. Usually you tend to see for any transurethral procedures. So what is this instrument? So you see here, it has got a dial-like structure. It has got a handle. Okay, and you have a couple of knives inside. Okay, couple of blades with knife inside. This is called Otis Urethrotome. What is Urethrotome? It is a special device which is used to calibrate the urethra, and it is also able to make a linear cut on the urethra at the 12 o'clock position. Okay, so where do you use this? We see here, if you rotate the dial, this will open up, and this will dilate the urethra, and over the top of it there will be a blade like this. Okay, this is called Otis Urethrotome. Okay, Otis Urethrotome. This is for any transurethral procedure, small strictures you can use it. There is one more Urethrotome. The Urethrotome means any device which is going to open up the urethra is called Urethrotome. Okay, this is called Saxis optical Urethrotome. See here, why it is optical? Because it has a telescope. You can insert a telescope and you can see. Okay, by means you can do this thing under vision. This is called Saxis optical Urethrotome. Okay, here you have a knife here. Here you have a knife here. Under vision, you open the stricture and you can cut open you can dilate the urethra. Okay, dilate the urethra. Okay, next, identify this question, identify this image. You see, what do you see here? This is as I said, this is a cross-sectional image. Probably it's a CT scan in the arterial phase. CT scan in the arterial phase. So what do you see here? You see an enhancing kidney, and you see a ill-defined or heterogeneously enhancing lesion in the kidney, which is also seen extending to the right side renal vein and IVC. That means you are probably seeing a right renal tumor with IVC extension. So this is again this is the same image. You see that's a kidney here, and there is a mass lesion. This mass is seen in extending into the long tubular structure on the right side. What is this? This is your IVC, and what is on the right side? You have your aorta. You have aorta. So that means there's a tumor is actually extending from the renal right kidney, extended through the right renal vein. It is extending proximally up to into your supracaval IVC. So I say this is RCC with right renal vein and IVC tumor thrombus involvement. So this is again a same intraoperative picture. What do you see here? What do you see here? You see a renal mass. So this is the IVC. This is the whole thing is an IVC. What you see is you have applied clamps like this. Okay, this is IVC. This is the left renal vein. This is the infrarenal IVC. Okay, this is the renal vein with the tumor thrombus. What are we going to do? We have to do sequential clamping. So that means, remember, the tumor thrombus has extended through the renal vein into the IVC. So that means the tumor is present here. So how are you going to seclude it? First you have to put a clamp on the infrarenal IVC, next clamp to the contralateral renal vein, and third clamp to the suprarenal IVC. By this you are continuously disconnecting. Then afterwards you are going to open a cava. You have to, along with that, you have to open the renal vein along with the IVC cuff, and then you have to evacuate everything, and then you have to do a venography. Okay, this is typically seen in locally advanced RCC. Now identify this image. Can you identify? So the first thing is a X-ray KV. This is called an X-ray KV. Why you say it's an X-ray KV? You don't see any contrast or stuff like that. Here what you see a radio opaque density seen in the right renal fossa. Similarly, you see a radio opaque density in the left renal fossa. Also, you see multiple small radio opaque densities in the left renal fossa, and also you see a big, well circumscribed radio opaque density in the renal pelvis in the region of bladder. So any radio opaque densities which are not normal apart from bones, they may be likely to be stones. It can be a case of bilateral renal calculi along with vesical calculi. Okay, this is the usual impression. So what is this image? This image, you see, you can find the difference between both of them. You see here, there is a opacification of your renal pelvis. Okay, pelvis, and the contrast is also seen nicely draining down to the ureter, nicely draining down to the ureters. Okay. Okay, so this film is called IVU. This film is called IVU. So what is IVU? IVU means you take a series of X-rays, you give IV contrast, and then you look for excretion, contrast excretion. Look for contrast excretion. So this is mainly to delineate the pelvic calyceal system. Pelvic calyceal system. Identify this image. Again, a series of images being given. Can you identify what you see here? See, remember, this you see the obturator foramen. This is a specific image wherein you see this is a contrast injection is being pushed into the urethra. Okay, this diagram, this image is called ascending urethrogram, ascending or retrograde urethrogram. So where do you see that? What are the indications? Whenever you suspect any urethral injury or you suspect any urethral stricture, you have to do this. This is the common conditions wherein you are going to do this. So whatever we are going to inject radio opaque contrast into the urethra. So what you see here is, you see here there is an irregularity. There is an irregularity seen. Also there is a narrowing seen in this part of the urethra, followed by there is luminal narrowing. Luminal narrowing is noted. So that means this is a case of a stricture urethra. Again, how can you identify the which part of urethra? That is by the presence. Okay, this is a bladder, this is a prostatic urethra, well, bulbar membranous junction, and you have your bulbar urethra, and then you have your penile urethra. This is the normal thing. So how do you identify? This is the penis, till the penis scrotal junction, it is your penile urethra, then the bulbar urethra. Then at the level of the obturator foramen, you have your bulbomembranous junction, and this is the prostatic urethra. So as you see here, there is a narrowing in the distal bulbar urethra, also in the proximal penile urethra. This is probably a case of a long segment narrowing involving the distal bulbar and proximal penile urethra. That is how you have to say. So again, identify this picture. This is again a similar picture. As you see here, here also you see this is an ascending. This is a case of an ascending urethrogram, AUG. Okay, as you see here, there is a significant narrowing. There is a significant narrowing in the bulbar urethra, probably in the mid bulbar urethra. Also, irregularities noted in the whole of the bulbar urethra. It's probably a case of a bulbar urethral stricture. Okay, right. Next, we will come to some of the uroradiology images. So again, identify this. So this also I already discussed. This is again an ascending urethrogram. But as you see here, you see there is a very small. The whole urethra is thinned out like a irregular pipe. So this is probably a pan-urethral stricture. So this is probably a pan-urethral stricture. Okay. So what is this investigation? This is a case. This is an ascending urethrogram. What is the diagnosis? The diagnosis of a pan-urethral stricture. Why do you say? Because the whole length is affected. What can you think of the etiology? The most common etiology is either balanitis xerotica obliterans or lichen sclerosis, or it could be a past gonococcal infection, sexually transmitted with urethritis, which is probably causing gonococcal infection, which should result in urethritis. Okay. Identify this investigation. What is this investigation? Can you see? See, this is again a X-ray KUB, but you see there is a contrast opacification in the pelvis. This is probably a cystogram. What is cystogram? Cystogram means we are putting a catheterizing the bladder and going to fill the bladder with contrast, with radiopaque contrast. What you see here? You see irregular margins of the bladder. Usually the bladder should be a ovoid shaped with a regular margin. That should be the regular bladder. Here what happens? Here because of some pathology, the bladder wall is diseased and it is not regular. There are multiple trabeculations and saculations are noted. So this is typically seen in neurogenic bladder. This is typically seen in neurogenic bladder. So this type of appearance is called Christmas tree appearance. Christmas tree appearance. Okay, this is typically seen in neurogenic bladder. Okay, so identify this investigation. So can you see here? What is here? This is an X-ray, and wherein you see a contrast is being injected from the contrast is seen in the urethra. This is the dilated urethra. You see bladder here, and what do you see here? On the bilaterally, you see grossly dilated system, kidney, okay, pelvic calcium system, gross dilatation is seen. This is probably a case of a micturating cystourethrogram or voiding cystourethrogram. This is usually done in a child, wherein you see the bladder is filled with contrast and ask the child to pass urine. So when the child is passing urine, you see an abrupt narrowing here. This is probably a case of a posterior urethral valve with proximally dilated prostatic urethra. Okay, and you see a bladder here, and what you see is there is bilateral vesicoureteric reflexes noted here. So this is a case of typical image of you see in a vesico-voiding cystourethrogram in a case with a posterior urethral valve. So what is keyhole sign? Keyhole sign is seen in ultrasound where you see two bubbles. Okay, two bubbles. Okay, just like a keyhole. One is the bladder, other one is the dilated posterior urethra. Okay. How does this child present with? Usually this child will present with inability to pass urine after birth, or sometimes the child may present with severe sepsis and features of acute AKI. Okay. How will you treat this child? First of all, we have to retrogradely put a catheter and you have to drain this bladder. Okay. And then you have to stabilize the child. Then you have to, if the child is stable, the creatinine is coming down, then you can go for a transurethral fulguration of posterior urethral valves. Okay. Right. Identify this image. This I have already discussed. Anyways, we'll see again. This is an X-ray KUB. You see a nicely radio opaque shadow in the plain X-ray KUB taking the shape of the calyces. So this is probably a case of a left-sided stag-horn calculus. Left-sided stag-horn calculus. So how this patient would have presented? This patient may be, they would have presented, they may be asymptomatic, or they may present with left loin pain, or sometimes with pyelonephritis and features of infection, or sometimes they may present with CKD also. Okay, so will you treat the stone even if the patient is asymptomatic? Definitely yes, because stag-horn calculus, they are notorious to silently cause kidney failure, and you have to treat the stone for sure. Okay, so what is the commonest composition of stag-horn stones? They are usually calcium triple phosphate stone. They are triple phosphate stones. Calcium, magnesium, ammonium phosphate stones. So how would you treat? The treatment option for such a big stone is you have to puncture, you have to do a puncture and you have to take it through a PCNL. Okay, PCNL. So again, identify this image. This also we already discussed. Again, this is a CT scan which shows a heterogeneously enhancing mass lesion in the left side of the kidney. As you see here, there is something which is extending like a serpentine into the IVC. So this is probably a left RCC with the IVC involvement, tumor thrombus involvement. So this is a locally advanced RCC. You have to do a metastatic evaluation. If it is negative, then you have to go for a radical cystectomy, or radical nephrectomy along with tumor thrombus excision. Okay. So what do you see here? Identify this image. Can you see here? So this is again a case of an IV. You see in X-rays, you see here there is a grossly dilated the contrast is seen taken up by the right kidney. It is grossly dilated, and as you see here, there is a C-shaped curve in the right-sided upper ureter, beyond which the ureter is not visible. So you see a right-sided hydroureteronephrosis, the C-shaped curve of the ureter, upper ureter. Probably you are seeing a case of a right-sided retrocaval ureter. Okay, it is probably a case of a retrocaval ureter. Identify this instrument. Now we will just project on some instruments. So these are the common instruments. You see, this is a most commonly used instrument, what is called a cystoscope. Okay, so cystoscope means it has got a sheath. Okay, it has got a bridge. This bridge you will connect over here, and through the bridge, this is called telescope. This is called cystoscope or telescope. Okay, cystoscope. So through this you insert the telescope. Okay, and through the telescope you can connect a camera head and you can get an image. Okay, this whole assembly is called cystoscope. This is usually used to visualize the bladder. So cystoscope can be of two types. One is your rigid, which is this one, or the next one is a flexible cystoscope. Okay, rigid or flexible cystoscope. So this is an actual picture of a cystoscope sheath. Okay, so this is what I am trying to say. Okay, this cystoscope sheath, this segment is a bridge. Okay, it is going to connect between the cystoscope sheath and the telescope, and this is a telescope, and this telescope has got a light pillar through which the light cable comes in. Okay, it's a telescope. So identify this commonly used instrument or an accessory in any urological procedure. This is called a double J stent. It has got two J's and the two loops. What is the purpose of this? Where do you do any ureteric or renal surgeries? Probably you take a stone out of it, then after the procedure you place a stent. Okay, why do you place a stent double J? This double J is a self-retaining. This will prevent the migration, spontaneous migration of the stents. Okay, this is called double J stent. How do they help? They help in passive ureteric dilatation. They also help in facilitate healing. For example, you do an ureteric injury and followed by do a ureteric repair or anastomosis, or you do a pyeloplasty. This will help in urine drainage and it will help in faster healing. Okay, right. Can you identify this instrument? Okay, this is one instrument wherein we are going to use specifically following a transurethral surgery, either a TURP or following a TURBT. So what are we going to do? You see here, it has got a bulb. Okay, so we are going to fill the bulb with saline. You are going to fill the bulb with saline, and we are going to connect it to the bladder. You are going to connect it to the bladder. So you are going to fill this fluid. You are going to fill this fluid into the bladder, and what happens? This is going to create eddy currents and turbulence inside the bladder. And once you fill and aspirate, release the bulb, this negative section will try to remove the contents of the bladder along with the turbulence, and it gets collected in this. Okay, this is called an Elix evacuator. Okay, this is also a modified form of Elix evacuator. It's called modified Elix evacuator, usually to remove bladder clots, prostate chips following TURP. Okay, this is mainly to evacuate the bladder. So what is this? You see a big glass syringe here, and the beak is something different. It remains like a lock to a cystoscope sheath. This is called a Toomey syringe. Again, it is one of the devices to evacuate the bladder. The advantage is it connects well to a cystoscope and helps in evacuation. Understand? Right. So identify this. So what do you see here? You get to see a series of metal dilators. These are called urethral dilators. Okay, what is this? This bend is to negotiate the prostatic urethra, to negotiate the bends in the normal anatomy of the urethra. These are called metal dilators. These are the different types of male urethral dilators. What do you see here? This is again a form of a dilator. This is called Hegar's dilator. This is called Hegar's dilator. The short dilator, blend dilator, is usually to dilate the female urethra. Remember, female urethra is very small. It is hardly about 4 centimeters. So this comes in different shapes. Okay, this will be of 1 French. This is really a broad French. Okay, you have to interchangeably use. Okay, you have to serially use to dilate the urethra. Okay. Now we'll come to some specimens. What you see here, this is a post-operative specimen. What is this? This is a post-operative specimen. What you see here, probably this is a case of a post-operative post-nephrectomy specimen. What you see here, you see a variegated big tumor in the bivalved. It's a bivalved specimen of your kidney where it shows a variegated tumor with completely occupying the almost the entire kidney. So this is probably a case of a renal cell carcinoma. What are the precautions to be taken during surgery? So this is again, you have to, that means what are the steps of a radical nephrectomy? You have to take extragerotal. Okay, you have to take along with the gerotal, because gerotal also contains some nodes. You have to remove the extragerotal fascia without opening the capsule. That is very important. So how do you differentiate a tumor, renal pelvic TCC from an RCC? So remember, this is again a specimen. This is again a post-operative specimen. Here you see, here what you see is you see a irregular shaped lesion in the arising from the upper pole of the kidney with some areas of central fibrosis and calcification. Okay, this is probably a left-sided renal tumor. Whereas here you see a kidney is normal in shape, but inside within the renal pelvis, you tend to see a soft, solid mass lesion is seen. So this is probably a transitional cell carcinoma arising from renal pelvis. How do you differentiate? Remember, this RCCs are mostly eccentric in location. They are going to destroy the reniform shape, whereas in TCC, which are centrally located tumors, the reniform shape is maintained. Remember, which of these is going to present early? Because it is in the pelvic health system, the TCCs are likely to present early with hematuria. Okay, now identify this specimen. Can you see here? That means here you see the kidney along the gerotal fat is there, and you see a hole of the ureter here, and as you come along, there is a disc of tissue at the end of the ureter. So this is probably a case of a right-sided radical nephrouretrectomy with bladder cuff excision. Can you see here? Okay, means the kidney is removed along with the ureter, along with the bladder cuff. So this is probably a case of a right-sided radical nephrectomy. So where do you do this? What are the indications? Usually we do it in high-grade transitional cell carcinomas, especially involving the renal pelvis or the ureters. So why do we have to remove the bladder cuff? Because the tumor seeding is likely to happen in the bladder cuff, which is close to the ureteric orifice. So the recurrences are more likely to happen in these cases. Okay, so that is why, to avoid the recurrences, the tumor seeding is likely to happen here, because for example, there is a tumor here, it is going to seed, and the recurrence are likely to happen in this region. That's why we have to remove along with the bladder cuff. This is called radical nephrectomy with bladder cuff excision. So can you identify? Some surgery is being performed. Can you identify what is being performed? Can you just tell me? So this is a laparotomy. This is done during a laparotomy. You see big vessels. Okay, this is the aorta. This is a branching into common iliac arteries, and common iliac arteries in turn divided into external and internal iliac arteries. Okay, and on this side you see again another big vessel, that is your IVC, which is divided into common iliac veins. So this means the retroperitoneum is exposed, and on either side you see a nicely crossing tubes on either side. This is your ureter. These are your ureters. Okay, so that means some form of lymphadenectomy is done. Given the condition, it could be an extended pelvic lymphadenectomy. It could be an extended pelvic lymphadenectomy. Sometimes you go till the origin of your inferior mesenteric artery. Okay, it could be a super extended pelvic lymphadenectomy. So what are the common conditions you do? You do it in a case of a CA bladder. Okay, or sometimes this kind of exposure with even more proximal nodes can be done in testicular malignancies. Okay, or sometimes in CA prostate. Now identify this picture. This is an intraoperative picture which has been taken. You see a man, you see a man. There is a lower midline scar, and there is something which is being done on either side of the inguinal region. And if you closely notice, there is a small surgery which is held on the penis also. Okay, so what could be the procedure which is being done? It's a simple procedure. It's a easy thing. A lot of clues in it. So this is probably a case of a CA penis with inguinal nodes. Okay. So what we have done a case of a partial penectomy along with bilateral inguinal lymphadenectomy. And along with that, you have created a flap. That means you have taken a flap on the lateral aspect and we have rotated it. Like this. So we have put a bilateral tensor fascial data flap. Okay. So along with that, what you have done here? What is another surgery you come in with this? You also go for a bilateral pelvic lymphadenectomy. Okay, pelvic lymphadenectomy. Okay, this is a case. This is a surgery usually do in advanced CA penis. Okay, identify this specimen. Probably this is a case of a. It may be quite difficult for you to understand. This is a prostate. These are the seminal vesicles. And along with that you have vast difference on either side. This is a case of a, this is probably a case of a post-radical prostatectomy. Okay, post-radical prostatectomy. This is how a typical specimen looks like. Okay, case of a post-radical prostatectomy specimen. Where do you usually do in usually localized CA prostate in intermediate or high risk patients. Okay, what is this specimen? Can you identify? So you see a catheter here, you see a big structure here, and what do you see here? You have an urachus and bilateral nodes. So this is a case of a radical cystectomy with bilateral lymphadenectomy. So what is this is usually seen in muscle invasive bladder cancer. Always remember, all radical cystectomies has to be combined with bilateral pelvic lymphadenectomies. Okay, so identify this specimen. So probably what is this specimen? This is probably a kidney. This is a bivalved specimen of kidney. What do you see here? You see a centrally occupying stone. You see centrally occupying stone. Along with that, you see grossly dilated calyces. Along with what you see here, there is a lipid ladder. Lot of fat deposition is happening. So what is this? This is probably a case of a xanthogranulomatous pyelonephritis or XGPN. Okay, xanthogranulomatous pyelonephritis. So again, what is this specimen? Can you identify? This we already discussed. This is again a bivalved specimen of a kidney wherein you see a variegated appearance. Okay, variegated appearance with central scar and hemorrhage in it. So this is probably a case of a renal tumor predominantly involving the lower pole of the kidney. Okay, right. So identify this specimen. This is again a post-operative specimen. So probably a kidney. What do you see in the kidney? There are lots of cysts. Okay, there are a lot of cysts. Even on the cut section, there are a lot of cysts. Some of the cysts are dark in color. So what does it mean? The cyst has actually bled. There is bleeding happen inside. It's called this is multiple. See, this is a enlarged kidney with multiple cyst. So what does that mean? This is probably a case of a autosomal dominant polycystic kidney disease. Okay, what are the implications? They also have other syndromic manifestation. They can present with cyst in pancreas. They can present with berryaneurysms, etc. And they are more notorious to develop end-stage renal disease at the later stage. Okay, this is probably a case of a testis, and you see a well homogeneous mass lesion arising almost the upper pole of the testis. Okay, on cross section, what do you see here? You see a clear cells. Okay, you see clear cells with clear cytoplasm, enlarged cells with hyperchromatic nuclei, probably case of a seminomatosis for which orchiectomy is being done. Now identify this specimen. Okay, this is an intraoperative picture. Can you see here? So it's a zoom picture. If you see here, there is a this is a partial penectomy specimen. I will just try to tell. What do you see here? You see a structure. This is your corporal bodies. Okay, corpus cavernosa. And what you see here, this is your urethra. This is your urethra, which is nicely demonstrated. And this is, if you remember, there is a tourniquet. That means we have applied a tourniquet at the base of the penis to reduce the bleeding. So this is a case of a partial penectomy stump. Okay, this is a stump after partial. So how do you do after the partial penectomy? You are going to close the corporal bodies and you are going to spatulate the urethra and you have to do a fashion a urethrostomy. Okay, right. Now identify this specimen. What is this probable specimen? So this we have already discussed. This again is a, you see a, this is a prostate and you see a big structure here. Okay, this is a case of a carcinoma bladder. Okay, if you see the bladder wall is thickened and the whole of the bladder is actually filled with tumor. It's a case of a radical cystoprostatectomy specimen. So identify this surgery. So this is a young child which she presented with a left-sided loin pain. We have done a procedure, probably a minimally invasive procedure. It could be a laparoscopic or robotic. And as you see here, what do you see here? You see the dilated pelvis, and this is the ureter. And what you have done is we have spatulated this. You have spatulated and in a procedure. This is probably a case of a left-sided PUJO for which we have done a left-sided Anderson Heinz dismembered pyeloplasty. That is being done. Okay, right. So what is this procedure? Can you identify? Remember, this is done in a small boy. You see, we have explored the inguinal. In the inguinal canal, you see a small globular swelling, and it is being transposed and put it in the testis. So this is probably a case of a right-sided undescended testis. What you have done is you have done a right-sided orchidopexy. Okay, since the testis is palpable in the inguinal canal, we have gone for an inguinal exploration. If the testis is not palpable, then you have to do a diagnostic laparoscopy. Look for the vessels entering into the ring. If the vessels are entering into the deep ring, then you have to open the inguinal canal. If it is not entering, then you have to look for any vanishing testis or intra-abdominal testis. Okay, what is the specimen? What is the surgery that is being done here? Again, it is a minimally invasive procedure. What you have done is this is a typical specimen. You see a big prostate along with the seminal vesicles. On either side, you have removed nodal packets. This is again a case of a radical prostatectomy. Now we will come to certain clinical scenarios. Okay, a 30-year-old female presented to casualty with complaints of right-sided flank pain following a trivial fall. On evaluation, she was anemic and CECT revealed the following findings. Can you identify? So this is a contrast CT. This is a contrast CT. What you see here is, okay, contrast CT. You see the kidney. In the kidney, you see some black colored lesion in the kidney. So anything which appears black in CT, it is rich in fat. Okay, it is rich in fat, and this patient presents with the right side severe flank pain following a trivial fall, and she is anemic. Anemic means something bleeding has happened. As you see here, something has happened here. So this is probably a case of a angiomyolipoma. That is, it's one of the benign tumor which can be diagnosed with clarity within in plain CT only. But what happened is, following a trivial trauma, since it's a very vascular tumor, this she has blood, this result in perirenal hemorrhage. That means she is bleeding continuously. What is the treatment option? You have to admit her, you have to stabilize her, you have to go for a selective angioembolization. That is the treatment of choice. Once you do an angioembolization, the bleeding settles on. If there is no time for angioembolization, if she is very unstable, then you have to take her, wheel in her for the emergency laparotomy, and you may have to do a life-saving emergency nephrectomy. So what is this image? This I already discussed. This is again a case of a micturating cystourethrogram. See, there's a catheter with bladder inside. So what happens when the bladder is filled with radio-opaque contrast? You see irregular borders, and you also see a faint opacification of your left-sided ureter. That means this patient also got a minimal left side VUR, which is very common secondary VUR following a neurogenic bladder. This typical appearance is called Christmas tree appearance. So identify this classical sign. So this is like a case of a direct angiogram, renal angiogram, where you see a string of birds, string of beads appearance. Okay, there is narrowing in the renal artery. This patient presented with a refractory hypertension, not responding to regular drugs. Okay, this is a case of a fibromuscular dysplasia, causing renal artery stenosis. So identify this classic image. Can you see here? This is again a cross-sectional CT with the contrast. There you see a radio-opaque contrast. You see a stone in the center, and there is a grossly dilated pelvis on the kidney. Okay, this is a typically seen in Beer-Pass sign. Usually we see this in xanthogranulomatous pyelonephritis. Okay, the features are centrally occupying stone with dilated calyces. Okay. So this come to a clinical scenario. This is a case of a 53-year-old male who presented diagnosed with the bladder tumor and underwent TURBT. Intraoperatively, he had a sudden jerky movement of his left leg following an abdominal distension and abdominal pain. So emergency CT shows the following picture. What is the likely diagnosis? Okay, so that means, so this we have done a CT. Okay. So there is a radio-opaque contrast in the subdiaphragmatic space. The patient has underwent a bladder tumor. During bladder tumor, the patient had some form of a jerky movement which has resulted in perforation. So probably it's a case of a intraperitoneal bladder perforation. Okay, so which has resulted in urine collecting in the peritoneal cavity. Okay. How to prevent this? This is probably following an obturator jerk. So this can be prevented by using bipolar saline TURBT, also taking the patient under deep general anesthesia, which causes complete relaxation of your muscles. How are you going to manage? Any intraperitoneal bladder rupture has to be explored immediately, and it has to be primarily repaired. Remember, intraperitoneal bladder injury has to be repaired, whereas extraperitoneal injury can be managed successfully with continuous bladder drainage. So this is that case. This is another case where you see a cystogram, you see contrast extravasation confined only to the extraperitoneal space in the pelvis. So this is called what is called as a molar tooth sign. This is typically seen in extraperitoneal bladder injury. Okay. Right. So this I have concluded the OSCE questions. Okay. So there are a lot of questions. This is an eye opener. For many times, first time you see them, you may not be able to grasp it, because most of these cases you may not have seen for the first time. But once you keep seeing cases like this, we will present subsequent set of case scenarios also. So this is mainly to get you exposed to the various subspecialties which you don't get exposure in your colleges. Okay, so all the best students, keep reading. We will continue with a lot of other programs also, and if you are in need of any specific topic pertaining to urology, you can always feel free to contact me at this number, or you can inform our staffs at DocTutorials. We are always there to help you out. Thank you.